Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
It's 2024, first episode of the new year.
It's an exciting time. Absolutely. This is year number
Into our fourth year.
fifth year.
Fifth year? Nah. Oh
Fifth
yeah,
year.
into our fifth year. It's our 4-year anniversary coming up later this month. It was, yeah,
Yeah.
oddly timed around some other world events.
Yes. Like COVID, for those of you not in the know.
Oh man. Yeah, no, that was a crazy time. So let's hope nothing like that happens anytime soon.
Yeah. Did you have a good holiday with the family?
Yeah, holidays were good. I traveled back and saw the family in Florida. Actually, when we left St. Louis, it was the same temperature in St. Louis than it was in Florida, but then quickly things plummeted back home here in St. Louis. So I had to remind myself that it's actually January outside, and it's reasonable that it's this cold right now.
Yeah, it must have been fun to be home. We got away to Charleston um, with the family, and for my family, when kids are all older, we have to go somewhere to be together. And it was great. It was really great. It's a cool town, and we had a blast.
Great food. Oh, I haven't been there in a while, but we need to go back. It's been a while.
Yeah, great food. Beaches are amazing. I mean, we were walking on the beach. It was 55 or 60 degrees, and the architecture is really amazing. The homes are beautiful. It was a good, 3-day visit.
So you survived the end of 2021 or 2023? Excuse me, I'm really missing
Yeah.
years here. I'm getting old now.
I did had a good last couple months. Actually, I looked at our division numbers for the last couple months and
Of course you did.
and it was a good month for the hand division. I'd say the last 2 months were both super strong as we would expect. And what's interesting is the numbers are, there's differences between us, but we're all pretty darn busy.
Yeah, yeah, no, I'm definitely feeling that. I've got a rough couple of clinics coming up. I've had the unfortunate every year it's weird. Like either you lose OR days or you lose clinic days based on the holidays. And I've lost a few clinic days this month because of either holidays or travel. And I'm gonna be feeling that in the remaining clinics.
Yeah, next year I'll lose OR days, and I'm always convinced it's better to lose OR days because if you have to find room for the cases, you'll find it. But it's tricky. It's tricky.
Yeah, absolutely. Well, I guess, old me, 2023 me would be stressing about which days I'm missing, but 2024 me is just gonna go with it.
You'll say that now.
Yeah, exactly. Any resolutions or affirmations as they call them now? New Year's affirmations that you want to put out into the airspace?
Talia had asked our family to each come up with a word that kind of summarizes what we want to do differently for the year, which I thought was kind of cute. Talia's was, be present when you're present in all aspects. And my word was listen, be a better listener. What's interesting is, especially as you're in meetings and we're all doing all these Zoom meetings and hopefully I am focused on the meeting and not multitasking, but if I'm focused on the meeting, sometimes I'm trying to figure out what I'm going to say in response, and that makes me a bad listener. So I'm trying to do better with being present like Talia, but also listening, really listening to people.
That's great. That's great. I mean, I think that your word of the year actually corresponds with two of my New Year's
Let's
resolutions.
hear them.
I actually went from I didn't make I was telling our fellow Emily Zoldos this the other day. I was not a New Year's resolution guy until the year I was a fellow. And I was so run down, as they would say now, burnt out in the middle of fellowship year that I I made my only New Year's resolution to that date, which was to work out 3 times a week, because I was just getting crushed as a fellow. And it's different now. We've got more fellows. It's different faculty composition, but that year I actually stuck to it and haven't missed a week since then, and have actually elevated that number. But that was my first ever New Year's resolution. But this year I have some aspirational and kind of immeasurable ones like you, but then also a couple of measurable ones. I said that I was going to listen more. It's actually number one.
Hmm.
And then also to think before I act or speak. So it kind of combines those two, kind of matches what you were saying. I need to leave a little more slack in the day, uh, just for my overall stress level. It's funny trying to, feeling like you're doing well in a lot of ways professionally, but then realizing maybe to sustain, I need to do a little less. So that's a tough pill to swallow. So we'll see how that goes mid-year. And then my measurable goals are kind of silly, but it's to do yoga, to stretch, and to do leg day consistently once a week each. So we'll see how that goes. That's measurable, and that's something I can actually check off.
No, those are excellent. I like both the aspirational and the measurable. I'm not a resolution guy. I will say though, I don't know when I started, but I really have been good about exercising. I think you've motivated me in part, whether and I'm having my knee replaced in 1 month.
Partially,
Um,
partially replaced, right?
partially replaced,
Yes.
thank you, in 1 month.
That's the
Um,
total knee in denial surgery. That's what we're
No, I just have medial arthrosis, but I've been really good about working out, and I've actually been lifting over the last kind of 10 months, and I at least 3 times a week. I've been pretty consistent, and I think I'll stick to it. Hopefully the knee surgery doesn't set me back.
That's great. Good for you. Is that something that you was your son at the age where you guys lift together, or your daughters for that instance?
Well, Kylie, my middle child, who's the collegiate runner, is really disciplined, like incredibly disciplined. And she was talking about how I think, benches 120, which is pretty awesome as a runner. And she's defined. My son is not a big lifter, so we kind of it's going to sound more impressive than it probably is. We put a home gym in. When my wife sold her business, she has the Myself Belts business, which was wonderful for 20 years. We took the belt room in the
Mm,
basement
hmm
and turned
hmm.
it into a gym. We put mirrors and a padded floor. It's really motivating.
That's awesome.
I'm surprised how motivating it is. So that's been awesome.
One of our partners has a really slick home gym. I don't know if you've seen Ryan Calfe's gym. It is pretty sick.
No, I did not know that.
I've only seen pictures. It looks pretty awesome. So, hashtag goals.
Well,
But
it looks like he works out, but let's invite ourselves over for a lift.
yeah, I don't know. Ryan's gonna embarrass me in another way too. So anyway, why don't we thank our first sponsor, and then we can check in with a new review and then talk about kind of the year in summary for our podcast.
That would be great. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
Nice. I think it's backslash as
It's that
opposed to
we always are,
forward slash.
practicing my elocution and I didn't get the backslash. I don't know which one it was. Anyway, we have a new review, and guys, it's the first review in many months. So thank you to Amy Pereira for leaving a review. 5 stars, of course, the only option. And actually, the title of her review is 5+++ stars. And Amy, thank you for writing this a fantastic, entertaining, and highly educational podcast. Thank you for taking the time to do this. It is invaluable to me and has helped my practice in all aspects.
So nice.
So nice. We're glad to help. It's fun to talk about this stuff, to talk about hand surgery, and I randomly have gotten some emails just from people saying thanks for doing the pod. It is really helpful. And some of them are patients. So I think that that's an interesting component of what we do. Obviously make sure that we have to keep things on the up and up in terms of what we say. But some of this stuff I think for you too comes pretty easy just to talk about what we do on a daily basis and what we're passionate about.
Yeah, I think you and I can kind of both relate to the fact that this has been a labor of love, and reviews like that, as we have continued to say, really help to inspire us to keep doing this. And you and I feel the same way. It's always hard to, find the time to do this, but once we start, it's always super fun.
Yeah, absolutely. So, those of you that are listening should know that Chuck and I did our annual check-in, and I've convinced him to re-up for another at least year. So we'll see how that goes. But speaking of the podcast, our publisher Buzzsprout sends us a year-end summary with some stats. So pretty cool. So Chuck, did you realize we recorded 31 episodes last year?
That's interesting because we had gone bi-weekly. So we exceeded our mark.
Bi-monthly or bi-weekly? I always get confused.
I think you can use either term. Every
Every
other
other week.
week. Which is the first year we've done that, but I have to say it has made it I think each episode is a little more special and meaningful and hopefully energetic. So 31 episodes, let's go.
Yeah, absolutely. And we are in the top 10% of all Buzzsprout podcasts. That's I think pretty impressive given our humble setup here.
Yeah, I've thought a lot about that. We have obviously a wonderful audience that is far more than hand surgeons or trainees, and there's therapists and there's patients, as you said, and there's some that just listen randomly. But it's not as if we have an audience that is as large as one can imagine. So we do have a finite number of people who might be interested, and I think the fact that we continue to have great download numbers, 2,000 plus a week, is really awesome.
So, but I totally agree. But if you're one of a sponsor or a potential sponsor, our audience is not finite and by any means, and will continue to grow. So speaking of audience, Chuck, where do you think our podcast was most downloaded in 2023, city wise?
Well, traditionally, I know the answer has been St. Louis, Missouri.
But you would be surprised that Chicago is actually our most popular city, St. Louis coming in number 2, Sydney, New South Wales, in as number 3, good old New York is number 4, and I actually don't know where number 5 is. I'm gonna embarrass myself, but, where is Omagh?
I don't know the answer to that. There must be. Hope those aren't fake downloads.
No, no, that's somebody who's really into the podcast, just, just listening over and over and over again.
Well, thank
But
you,
thank you.
Chicago.
Yeah, thank you, Chicago. Thank you, New York. Thank you, Sydney. We love having everybody listen. And let's just run down our top 5 episodes in terms of downloads. Number 1 was with Amy Moore and Dom Power about why mess with a good thing, diagnosis and treatment of carpal tunnel syndrome, our collaboration with the British Society. Number 2 was a discussion of claw hand. Number 3 was how the times are changing. Number 4 was mallet finger made more exciting. I'm pretty sure that was with Macy. And then the 5th was the what's new in hand surgery episode. So super cool to see what everybody's into.
Yeah, I love that. And what is what? Let me go back to what you said before, because you were right when I said our audience numbers are potentially finite. What makes this podcast different is the engagement, and I think that really does distinguish this podcast and sort of the maybe I'd call it a family of podcast listeners, and I think that's why our sponsors really do appreciate what we're doing here.
Yeah, absolutely. And I think that we joke about the sponsor thing, but it is something that enables a whole a group to be reached and to be spoken to. But also for us, it's I have to say we probably still will be we would still be doing it even without the sponsors, but it certainly makes it a little more exciting to read copy and do all those sorts of things. And I'll close with one stat. 125.9 thousand downloads. So 125,900 downloads.
For 2023.
2023.
Thank you to everyone listening. That's amazing. It's amazing.
Yeah, it's pretty cool. I think it's one of those things where it continues to grow and it continues to be fun. Well, speaking of stuff that's fun, I will mention our next sponsor because the message is really cool.
Can
So
I can I do the honors?
yeah,
It would feel better.
absolutely,
It would feel better if
absolutely.
I did. Our sponsor, Checkpoint Surgical, is supporting the Washington University inaugural peripheral nerve course, April 5th and 6th here in St. Louis. Faculty of this course will include yours truly, Dr. D, Dr. Mitchell Pett from plastic surgery, and Dr. Wilson Ray from neurosurgery. It is a combined ortho, neuro, plastic surgery, nerve course. You can register at the link in the podcast description or on nervemaster.com. We really hope to see you here because this course is excellent. I've seen the syllabus and the speakers. It's fantastic. This is not part of the copy, but you got to be here.
I think thank you for saying that, and thank you for offering to read that. I'm super excited about it. Mitch and Zach and I have been working hard to put this together. Our keynote is none other than Dr. Susan McKinnon. Would have it no other way for the inaugural WashU Peripheral Nerve course, and hopefully this is something that resonates and finds an audience. We've had a lot of industry partners step up to sponsor it, knowing that it's going to be a great event and. I'm super excited. It's been a combination of didactics, lectures, and interactive sessions, as well as cadaver dissections. The opportunity to do your own dissections, to see pro sections done by the faculty, and it's pretty cool. All the faculty are either current WashU faculty members or alumni in some way of one of the peripheral nerve programs.
Yeah, it really is. I'm super excited to see how this goes, and expect wonderful things and expect it to become part of our yearly calendar.
Yes, let's hope so. So why don't we get to talking about some cases, or at least a clinical topic? Whenever we see fans on the road, they talk about how much they want technique and detail episodes. And I had a case recently that it reminded me of. We haven't covered kind of the nuts and bolts of Keenbox and some of the surgical techniques that come along with it. So why don't we do that?
I think that's great. I think that's great. We have taken some deep dives and we can sort of hit on things. We don't want to be overly repetitive, but I think an overview is a wonderful idea. So let's do it. Tell us a little about your case.
Yeah, so let's say mid 40s woman who's had wrist pain for a few
Young,
years. Yes,
young woman.
very very
Okay,
young
okay.
woman. Has had wrist pain for, a couple of years on and off, but it's really started to get worse in the last couple of months. She comes in, has some plain films taken, and their suspicion for Kienbach's disease based on some sclerosis at the lunate, which is pretty much diagnostic. She had also come in with an MRI, which was confirmatory before that I saw her. So I think, how do you start to think about that patient, both in terms of, you've kind of gotten to a diagnosis, but physical exam, what do you do? And then how do you scrutinize the radiographs and the imaging to help kind of guide what you do next?
Yeah, I think it's a really important points. Sometimes we often have patients come in with wrist pain, but it's not common that the complaint is central dorsal wrist pain. And so when we have that patient, initially I'm like, wow, could this be Kienbach's? Because even in our practices, Kienbach's is not all that common. I probably see 5 or 6 patients a year, maybe more. I don't think dramatically more patients with Kienbach's. And so that central dorsal pain for me is the hallmark, and you can almost put your thumb on the lunate. So distal and ulnar to Lister's tubercle and pain there. I won't say it's pathognomonic, but it really has to get us thinking about Kienbach's.
Yeah, to me, one of the things that you taught me when I was in training, and Dr. Gelberman, the same thing. I mean, point tenderness over the lunate is Kienbach's until proven otherwise in the isolation, in the absence of any other clinical findings.
Yeah,
Um,
I was going to say, then along with that, I try to, better understand the integrity of the scapholunate and lunar triquetral ligaments. I always check impaction testing because what we know, that's been proven in the literature, is there can be associated soft tissue conditions such as SL, LT, or TFC pathology, but generally it's isolated dorsal central wrist pain.
yeah, absolutely. I mean, I think that the issues with the intercarpal ligaments are secondary, or the sequela of the main issue at the lunate, but certainly something that you should appreciate, either in terms of how it guides your treatment or how it portends a prognosis. So I mean, what's the for you, somebody that's, say you look at their x-rays and they don't have a lot of, eventually with this condition, the lunate will start to collapse. And as the lunate starts to collapse, you may see some loss of the carpal height. And there are a couple different ways to measure that. But, as you start to see these patients, if they have a relatively maintained carpal height, does that guide your treatment? Does that change your treatment more than if they have started to collapse?
Yeah, if I may, I want to take one step back, not for too long. So first of all, just make sure we're all on the same page. Kienbach's is unexplained avascular necrosis of the lunate. It can be the entire lunate and usually is, or sometimes it's not quite the entire lunate. And it may be radiographically difficult to diagnose, and that's where an early MRI can sometimes be helpful. As you said, you can see a sclerotic line and you can see collapse of the lunate, and eventually you see collapse of the carpus and arthritis. And so the case you're presenting sounds like a pretty maintained lunate morphology without dramatic collapse, but with pain and MRI changes. And so what we worry about is natural history. Now, to my knowledge, there's no wonderful natural history studies, but in this patient with pain, um, presumably a period of non-operative intervention, which has failed to resolve the pain, then I do think about surgery. Is that sort of where you are with this patient? Or are there non-operative steps we should discuss?
I actually tried casting her because I thought that there might be a role of addressing the symptoms. We didn't have any signs of collapse. And at that time, the other thing that needs to be noted is whether there's any sagittal instability in terms of the scapholunate interval. As you mentioned, the SL ligament can be compromised as the lunate starts to structurally deteriorate. And you actually have written a nice paper about the position of the scaphoid. I know that we all used to measure kind of um, the SL angle, but for this, it probably is more important to measure the radius scaphoid angle. Is that not right?
Yeah, that's what we said many moons ago. I still believe that's helpful. When you try to measure the scapholunate angle and you have deformity of the lunate, it's hard. And so having a measurement of the radius to the scaphoid is much easier to measure. And we sort of have a break point of about 60 degrees. So if your scaphoid is flexed more than 60 degrees, to us, it indicates intercarpal collapse. And then you're at real risk of arthritis. And so one thing that I know you and I agree on is we don't want to watch a patient go down that pathway. And so, we want to do a couple of things. One, we want to address pain. And two, we want to hopefully change what is potentially the natural history of going down a wrong, or unfortunate pathway. And I love the idea of casting first because, in this situation where surgical treatment is not always a slam dunk, I think trying to exhaust those options um, as long as we don't take too long in exhausting those options, I think that is really important.
Yeah, for me, for a patient without, any, substantial carpal collapse, and without any, an advanced radius scaphoid angle, that to me is a patient where I'm going to try to go a little bit slower. Understanding fully that I'm probably not going to alter the natural history of this condition, but like you said, there is no really good natural history study to know when that carpal collapse is going to reach a tipping point, and you're going to see, the accelerated path of arthritis. So I mean, I tried casting and still persistent pain after a couple of months of casting, so we had a decision to make there. um as you mentioned, there are a lot of different ways to treat this surgically. I think our original understanding of treating this surgically was based on some observations about the ulnar variants in some of these patients. So what's your understanding of that literature in the past, and maybe how that thinking has changed or has not changed?
Yeah, I would say the single most, I'll say important, the single most important radiographic parameter for me in assessing these patients is and remains ulnar variance. And so if the ulnar variance is negative, that is, the radius is longer than the ulna, and we are treating pain, then we have a very good, reliable surgical option, which changes the loading patterns through the carpus, and that is shortening the radius. And if I had to pick one surgery that I thought was most reliable, that would absolutely be it. If your ulna is neutral or longer than your radius, further shortening the radius is probably not ideal. There are different ways to try to change carpal loading, such as capitate shortening or other options that I can name a bunch, but they're not really relevant. But for me, if there is ulnar negative variance, shortening the radius is my first choice for sure.
Yeah, no, that was originally described by none other than Dr. Gelberman, I believe. And I think there have been some papers otherwise that have said, perhaps that's not as strong of an association. But certainly, I think that's what the experience that most hand surgeons have, is that it is a patient with ulnar negative variants. And the idea of shortening the radius, just to reiterate what you said, is to take some of that pressure off of the lunate, where that interaction at the lunate fossa is. And perhaps by shortening the radius, you'll load the ulnar carpal joint more, and alter kind of the natural, or the pre-surgical distribution for that particular wrist.
Yeah, that's exactly right. It used to be said that you can consider that option for stage one, two, and 3A, that is those without carpal collapse, but in 3B or panarthritis stage four, you wouldn't. I think people, and there's an article out of here in HSS that really suggests that even in 3Bs, it absolutely can be considered, especially when that radius is longer than the ulna. Um, so that is always on my mind as a first line treatment.
Yeah, you're reminds me of something I was telling Emily, our fellow in the operating room. For this case, because I have, it's not a common thing to do. I actually took out my notes from fellowship, which are stored in a handy Google Doc. And I was reviewing them, and then I was talking to Emily about the condition and sort of your paper about the radius scaphoid angle, Ryan Calfee's paper that you mentioned about potentially treating 3Bs with radial shortening. And I was like, "Do you know who wrote those papers?" She nailed it. And the classic Goldfarb contribution to literature, like one of our listeners said in the past, like a workman hammering nails, just continuing to have an impact on our current generation of learners.
Well, I'm flattered and love that. Thinking back to our conversation with Steve Moran, One of the things that's frustrating about this diagnosis and treatment is part of the problem in defining the best treatment is not always isolated. And so we often combine treatments, and I am guilty as charged. And so let's take your patient. If you have a 45-year-old young female who is ulnar negative, and you say, I have a solution for you, I'm going to shorten your radius, I will often add a vascularized graft, 4 or 5 vascularized graft. Um, I think it is not a negative in any way, and bringing the vascularity can be helpful.
Yeah, no, I think it would be nice to approach this truly scientifically and do one procedure at a time. But I think you've only got a certain number of procedures in the can for this patient and any patient really. And again, while you want to wear your, academic scientific hat and say, all right, well, let's do this, and if this doesn't work, we'll do that. I agree. I think this tends to be a condition in which we combine treatments because we don't have a firm grasp of which one really works, and honestly that study's never going to happen. In terms of getting it done from a rigorous perspective. So I think we end up combining treatments a lot. Before we jump into the surgical options a little more, is there any role for steroid injections in this patient?
If the patient said to me that she needed to do X, Y, or Z and couldn't think about surgery for 6 months and was having pain, sure. But as far as altering the course of the disease process, no, not whatsoever. So it's not usually something I offer, unless the patient has a real need to delay intervention.
Right, and I think that's something that the same way I would approach it. Before we dive into some of the technique details for the surgeries that I think we both would choose for this patient, what do you think about like core decompression of the distal radius? I know there's been some interesting results, particularly that have come out of South America for that.
Yeah, I think there's 3 procedures we should briefly discuss. Core decompression is one, and to be very clear, core decompression is a minimally invasive procedure where it's almost like harvesting a distal radius bone graft, is the way I think about it. So you could take off Lister's tubercle, use a curette, remove some cancellous bone, sublunate in the distal radius, and whether that changes loading patterns or leads to increased vascularity in the area, I don't know, but reports are pretty strong.
Yeah, and I think that's the kind of thing where if done in a very thoughtful and deliberate way, can be done relatively quickly, with leaving opportunities for other surgeries down the line in terms of not creating a ton of scarring and allowing a quicker recovery.
Yeah, totally agree. The second surgery I would say is interesting is arthroscopy, and of course, it's in my toolbox, and I enjoy arthroscopy. It's a big part of what I do. I have to say the jury's out a little bit for me. I think it's certainly a easy risk to scope. Information is helpful. We learn about the SL, LT ligaments, TFCC, as we said. We learn about the status of the cartilage. If there's a fracture of the lunate in that coronal plane, we can see it. We could theoretically guide screw placement, but I don't know that it's a definitive treatment. I think it could be an adjunct, but it doesn't really stand alone for me for most patients. Do you think about it differently?
No, I don't use it. Part of it probably is the fact that I use it less frequently in general than you in terms of general arthroscopy. I think you mentioned one thing that I think is super important. That coronal plane shear fracture or that coronal split, not always a shear, but that split in the body of the lunate can be kind of challenging. And not knowing about that ahead of time can make surgical treatment quite tricky. I usually get that information on advanced imaging before surgery. So fortunately, this patient, prior to coming, already had an MRI. So that was helpful to know that that wasn't there at least at that time.
Yeah, really well said. I couldn't say it any better. And so I have mixed feelings on screw placement for that coronal fracture. I think it's just tough to think a non-vascularized lunate is going to heal, but I have put screws in, they never failed. I'm not convinced it always leads to healing. Um, and then the final option, which I look really, really, really want to hear your opinion of, because I've sent you a patient recently, is what's the role for basically addressing the nerves of the carpus in a patient like this? So if you can do a neuroablation procedure for Kienbock's, have you done it? What do you think about it?
I haven't done it in particular for Keenbox, but I think it depends on how you do it and the way you set up expectations. If you do purely a PIN AIN neurectomy, I don't know if you're going to get the complete true denervation of the wrist that you're looking for, but it might be enough to buy some time. In a way that's similar to the core decompression. I mean, you could do that in a pretty relatively quick and minimally invasive manner, and allow the patient to move on, and maybe you get some good bang for your buck. Fully expecting that at some point you'll be back for a more definitive surgery, but maybe the timing isn't right for that patient to have the bigger surgery. My understanding of the results, at least, from the Mayo series, was interesting. Denervation in that manner of AIN, PIN neurectomy, a partial denervation, did best for slack and snack, and was less predictable for Keenbox. So, that gives me a little bit of pause in terms of how to utilize that surgery. But again, for the right patient, it's another thing to have in your toolbox.
Is it more, therefore, of a salvage type procedure for you? So in other words, let's say you go through everything we're about to talk to and patient's still not better. I might consider a PRC as a salvage procedure. Would you instead consider a denervation?
I don't think it's a salvage. I think it's a bridge. And I probably would do the denervation as part of the PRC, kind of a belt and suspenders approach, or the denervation as part of one of the, carpus preserving surgeries, like a radial shortening or a 4+5.
Excellent, excellent. So if we're going to talk about, so why don't we, if it's okay, why don't we briefly talk about radial shortening, and we can say a few words about the vascularized grafting, but I think we've covered that pretty well in the past. So when you shorten, I'd love to know dorsal or volar, hardware choice, expected healing time, any tips or tricks to your treatment.
Yeah, I mean, for me, because I was coupling this with a 4+5 vascularized bone flap, I went ahead and did the dorsal osteotomy and dorsal plating, to keep it all through one approach. I remember very vividly doing these cases in fellowship, and some of my notes were from a radial shortening with Dr. Gelverman, and kind of doing it from the volar side, getting out the 3-5 LCP plate, kind of more diaphyseal as opposed to metaphyseal. But clearly, this could be done with a volar locking plate, utilizing that oblong screw hole to help you dial in your shortening. But for me, it was the convenience of already being on the dorsal side. I went ahead and did this from dorsal. How do you typically decide what you're going to do, which approach?
Yeah, I have separated my incision. So I go volar. I place a relatively distal DCP. I've definitely done volar locking plate, shortening osteotomies. I have to say they're just not that satisfying. And so I get more joy out of using a DCP, 6-hole, usually 3.5, maybe a 2.7 DCP, get good compression, and you're shortening usually a millimeter or two, so it's not challenging to shorten. Um, and I like it, and therefore I prefer to go volar. My caveat is healing takes forever. Radiographic healing takes forever in these patients.
Yeah, I think that I'm more looking at and feeling the lunate and checking for whether there are any changes in that, more than anything else. And I think if you're going to go the volar route and use that 6-hole DCP, make sure that you've got a tabletop bender, because not everybody's got the forearms of Chuck Goldfarb and can bend a 3-5 plate manually. So the tabletop bender is helpful.
For sure. Absolutely. Good point. And yeah, but you can do it dorsal, you can do it volar, you can use hardware of choice. Thankfully, the radius metaphysis or even distal diaphysis will heal. And so that's not part of the worry. It's just how much do you shorten? And again, I don't know that anyone has the answer. Are you shortening going for neutral variance, or are you just shortening a bit? Um, I tend to shorten a couple of millimeters, but taking care not to over shorten.
Right. Certainly don't want to overshorten. I wouldn't want to go into a on a positive situation. And for me, this patient was we were shooting for neutral. The one thing I like about doing this dorsally also is that my worry is that, when we're using our saw, we're not in a fracture situation. So I worry about what's going on the far end as that blade is coming through the far cortex. I have more control of things going from dorsal to volar in terms of I've got my pronator quadratus buffering me on the volar side. So I know exactly where my extensor tendons are because I'm doing it from dorsal, and I have the PQ on the volar side. So, Honestly, even when I do a volar approach for a distal radius malunion, so a different indication, but if I'm doing a malunion correction, I tend to be a bit of a chicken and I make a dorsal counter incision to look at my EPL and get it out of the way. And, just because I know that you've got to fully release everything, periosteum, callus, etc., in that setting to fully get that thing hinged so you can get the correction you want.
I think that's really well said. And for the younger, either, residents or fellows or young attendings, I think that's really good advice. When you leave the OR, you need to be absolutely comfortable that you've done things in a way where you're confident you've done them right. You do not want to lose sleep over, did I satisfactorily protect the tendons? There's plenty of things that are going to cause you to lose sleep. Don't let small technical things do that. And if you need to make a counter incision, make the frickin' counter incision. It is no big deal.
Right, and it's not like it's a formal dorsal approach to the wrist. It is, and I warn patients if I'm doing things mainly from volar that they might have a counter incision. Certainly adds to swelling, but you can do things in a way that allows you to feel comfortable. There was something interesting in this case as we did our approach. There was, and I think you've probably noticed this. There's so much boggy synovitis in the capsule when we're approaching our lunate. And then, of course, by the time that we had gotten to the OR, when we were taking our initial X-rays, there is a flexion of the scaphoid, that ring sign, and our radius scaphoid angle was elevated. How do you, at this point, do you prioritize correcting the position of the scaphoid before you do anything else, and how do you maintain that?
Yeah, I think it depends on why. So it is an SL pathology? Usually not. There's not usually a frank tear. There can be, as we've discussed. Is it really the collapse of the lunate? And so if you believe Steve Moran, and Steve's a friend, and you think when you open up the lunate from dorsal, can you basically expand it to accept your graft, and will that help correct the SL angle? I honestly believe that once the scaphoids flex, I'm not sure I can do something to permanently put it back in position unless there's a tear and I treat that. But thankfully have not had to do that.
Yeah, I know. I think it's challenging. I mean, for me, we went ahead and put a joystick in the scaphoid, got it out of flexion, and I put a pin across the distal scaphoid into the capitate to secure things, and then kind of worked from there.
So I love that solution. I recently did a Keen box in a 13-year-old, and I always pin the carpus in those patients because what you're doing, you're getting the scaphoid back up if it's flexed, but what you're also doing is you're unloading the lunate during the healing process. And so I think that's a very, very good technique and very reasonable approach.
Well, it's a good thing I learned it in fellowship. Went back and looked at all my notes.
So let's briefly talk about the 4-5 graft. I assume you use a 4-5.
Yeah, 4 or 5 for this one.
Yeah, my one complaint about the 4-5, I do think it's a better graph than the 1-2, because it seems to be just more durable. The problem with the 4-5, in my experience, is it's very ulnar. And so I'm usually finding I'm taking cortical bone on the ulnar side from the ulnar side of the radius. But there's usually good cancellous bone. The blood vessels are welded nicely to the bone. And I usually feel pretty good about it once I've elevated it.
Yeah, to me, it's the elevation usually feels pretty good, but the inset is the less satisfying part of it. In terms of, as you're trying to delicately put this thing in, you feel like you're probably being a little rough with it. But for this one, the elevation went well, well-defined blood vessels. It was ulnar, like you said, which obviously can affect the way how you can swing that and drop it in. But do you have any tricks on how you inset it and how you secure it?
Yeah, I have to say, when I first started doing this procedure, I would try to take the dorsal cortical bone with blood vessel and lay it in dorsally so that all of the original dorsal cortical bone was sitting dorsally on the lunate. I don't do it that way anymore. I generally inset it so that I kind of dunk it into the lunate bone. And ideally, I've dug a nice trough, and in fact, as far as I can go volarly. And so I can really inset it nicely with the cortical strut proximal to distal. And I
Hmm.
think it sits better. I think it does provide a strut. I think it's more likely to stay in place. And I might add a little capsular imbrication over the top to minimize the chance of it popping out. But that's how I do it. How do you handle it?
I did it like the way that you initially described it in terms of laying it on dorsally, and to me it was like, well, it's just sitting there pretty nicely. Again, this wasn't a case, fortunately, where we had the coronal fracture and we didn't have a substantial amount of collapse, so we weren't really trying to jack out the lunate that much. So I mean, overall, pretty satisfied with how everything went, and then we did our shortening after that, and you know, I'm curious to see how you would handle the post-op protocol in terms of length of immobilization, and when you would talk to the patient about when to expect something to change, either in terms of how they're feeling with their wrist or healing of that osteotomy.
Yeah, with a vascularized graft, it's an automatic 6 weeks of casting for me. You don't need it for the fixation of your shortening, obviously, but for me, I do feel comfortable with 6 weeks of casting and then out of the cast at 6 weeks, and either some home therapy or some formal therapy with a removable wrist brace, usually for 8 to 9 weeks. It's interesting. I don't know if that's how you handle it at all, but I've been pretty happy. And by the time they come out of the cast and start moving, I think we're headed in the right direction.
Yeah, no, that's been my experience. And, I'm not focusing overly on radiographs. I am kind of palpating the lunate. And I remember being taught that that was, the biggest measure of whether you have succeeded is whether you can take that point tenders over the lunate and take it down.
Love it. Hey, I'm glad I think this is a fun episode to talk about. You and I had mentioned talking about ulnar shortening osteotomy. I think that's a topic we need to hit on. I think it's a great topic, partly because it's probably one of my top five singular favorite procedures that I do.
I'm glad you like it. I enjoy it too, but I'm glad it's in your top five. I have some others I'd put in my top five. We should actually do a little, just a quick rundown of our top five favorite surgeries. I'm sure we've done it at some point, but maybe they've changed.
Yeah, we used to do a lot of more of the number stuff, top five, top seven. I still like those kind of episodes. We got to do more of that in 2024, baby.
All right, sounds good. Well, I hope that you enjoy the rest of your evening and look forward to talking again soon. Thank you to everybody for listening.
Thanks, everybody.